So Joanna, Eleanor, sorry, I might just start off with if you could tell us a little bit about yourselves, what you do, and how you ended up in sexual health work.
Yes.
So I'm Eleanor. I've met only one of you before. I've been a nurse since 1985, and I fell into sexual health absolutely by accident. I had been working in Kalgoorlie Regional Hospital as a registered nurse and also a midwife. We moved to Callabunda in the early noughties, and I was working for a GP practice just because I had two boys, no family in Perth, and my husband FIFO, and I asked my boss if I could do a pap smear course, and that's how I fell into sexual health. Yeah, purely by accident. It was never on the radar. I was going to be a cardiac care nurse. But
Really?
Since 2004, sexual health has been it. And so now I'm working for Derbyl Yerrigan. I've only been there 1 year and 2 months, and I'm a part of the sexual health team at Derbyl.
Oh, that's so good. Yeah.
So I'm Joe. I've been a nurse for about 6 or 7 years now. And basically I fell into sexual health by accident as well. Completely did not expect it. I was going to be an operating theatre nurse. Can you believe, like, considering how social I am? I worked at Queensland Children's at Perth Children's for a number of years, and then I was just like, I want to see change. I want to do something in the community. I was just searching around, didn't think of sexual health. I applied for M Clinic, not knowing initially what was a sexual health clinic. So I was just like, and then I got the interview and I was like, oh, wow, okay, cool. And then I was like, oh, wait, it's a sexual health clinic. Wow, I wonder if I'm experienced enough to do this. I've only done operating theatre and ICU nursing. And I was like, okay, let's give it a go. But apparently my charisma sort of just cut through, and I clearly...
Right.
And then just like, they just sort of tested you on the spot, like, can you talk about these different sexual health topics, in particular like gay sex topics? And I was like, yeah, I can talk about it, whatever. And yeah, so since then, so I've been a sexual health nurse for about 4 years on and off, mostly male sexual health. And so I've worked as a registered nurse initially at M Clinic, which is part of WAC or WA's council, then became the nurse manager for a little bit, and that was really stressful. And then I sort of did sexual health nursing, but as a general practice nurse at View Street Medical, which does they see a lot of they do a lot of trans management there, and HIV, and they've just basically got all these really good HIV S100 prescribers there. So that's sort of what attracted me to that role too. Then I took a break and went to public health nurse at Aqua for a bit, and now I'm at Derbyl for the past 3 months. But it feels like a lot longer. Yeah. So yeah, that's where I'm at right now, part of the sexual health team.
Nice.
Yeah.
Do you want to share?
Oh, me? Oh, I'm included. Oh,
Yeah.
God. Well, I worked with Eleanor back many years ago in Kalgoorlie Regional Hospital, as we were both midwives there, yeah. And then I got a job as a remote area nurse in a community called Kunana, which is no longer a community. It's about 170 k's from Kalgoorlie. And what I noticed, particularly working as a remote area nurse, is that sexual health was absolute taboo. And a lot of the young people, particularly young men, wouldn't even come to the clinic in the day, but they would be wanting to see somebody in the evening when nobody was around. And for some reason, I just had this connection with some of them, and I felt quite comfortable, to have those yarns with them. I don't know where it comes from. I grew up in a strict Catholic family, and, I don't know where it comes from, but it must have been this wire in my head that all of a sudden it found its way to my mouth. and then I just could talk about it. So then when I was working in community health, I asked if I could do a pap smear course. So I went to family planning they were family planning WA, I think back then, and I did the Pap smear course, or sexual reproductive health course. If anybody's interested, they still deliver that training. It's wonderful, and it's a really great introduction into sexual health. And I've sort of been always carried that sexual health hat with whatever job has brought me to my current job. So yeah.
Nice. So the question might be a little bit controversial, depending on his answer. So what does a day in the life of a sexual health nurse look like for you in community?
So for me, in Derby, it's completely unstructured. I would like to be a control freak. I would like to be able to plan my day out, but it never happens that way. I'm always sidetracked by a phone call from MCDC or a phone call from a patient or something. But I normally start my day out by having a look at all the incoming results, and I'm particularly only interested in the STI BBV ones, and I flag anyone who has a new diagnosis, they haven't been treated, and then I'll send them SMSs to make an appointment, or I'll follow up people who have ignored those SMSs. And then from there, the day just sort of falls into whatever. I could be helping out the visiting gynecologists. That's once a month. We have a visiting sexual health doctor come and do IUDs once a month, so I might be helping out with that. Or we're providing syphilis point of care training to individual staff. We're also teaching staff how to collect specimens, because when I'm going through the results, sometimes I'll find results haven't been, or tests haven't been collected. Pathwest will let us know, so then I find out why that specimen wasn't collected, follow it up with the individual staff member. We're always looking at stock, so I'm filling the condom vending machines in the toilets, and making sure that we've got enough LA bicillin supplies and vaccine supplies. It just, I don't know, it just keeps going on and on and on and on.
Yeah, and you get in the car sometimes and have to go.
Yep. So we go finding patients out in the community, a lot of liaising with MCDC and homeless healthcare, and sometimes we'll do combined jobs. So we'll actually team up with them and go out and do a job. So always different, always interesting for me.
And then also in between all of that, we also do have like quality improvement initiatives. So we have registers for all the different BBVs, and also for syphilis as well. And so patients that need that regular follow-up, we like to keep them on the books and just make sure that they're followed up adequately. And if they're not followed up with our service, are they being followed up somewhere else? Just making sure that they're being managed effectively for their bloodborne virus. So that's been a recent thing that I guess I've been doing. And yeah, so a lot of quality improvement in the role.
With our doctors at East Perth, I'm also opportunistic. They'll send a patient to me for Implanon insertion removal and cervical screening as well. So making sure that our clients get holistic care. It's good.
Yeah. So going back to, so you start off the day by actually having a look at patient results. Okay.
Yeah.
So that's basically all results, and then you go through and flag the sexual health.
Yeah.
Okay.
So we can, through Communicare, we can actually, it's organised them so that you can just see the STI ones and sort of scroll through and just look at the ones that you're targeting.
Yeah. Okay.
And then we put them in a register so that we're like, okay, well, we'll leave it to the clinicians to follow up. But if they're not followed up after a certain period of time, then that's when we get involved, you know?
Okay.
But I like to have a look at the results and send the person an SMS before the doctor has set the recall. And it's just so that, because I do that first thing in the morning, it gives the nervous people a chance to actually ring up and grab one of the available appointments, which is handy, so that it's not too delayed for them.
Yeah.
Because Derby's quite interesting. We do a mixed sort of appointment versus walk-in appointment sort of sessions. So like you can either come in for a walk-in appointment as long as you rock up before 8:30, I think there's even some after lunchtime if you're up around the lunchtime period, but it's mostly appointment based. So it does involve clients calling in too, just because of the mass amount of clients we have to see across the 4 clinics.
Okay, so for example, you've got have I got time to ask these questions? Yeah. Okay, a positive syphilis.
Yep. So I go into investigator mode. So my first thing is contacting MCDC. I look in their notes. So the first thing is look in their notes, see if they do have a past history of syphilis. If it's not known to us, I contact MCDC, and then if it's still too early in the day that I can't get hold of them, I might even do a ring around to all of the labs to see if the person has had prior syphilis results, either negative or positive, because we want to know if it's a new infection, if it's an early infection, or if it's a late infection. And if they've had syphilis for a very, very long time, I think that the Northern Territory Syphilis Register is an absolute gem. They will quite often have information on our clients that nobody else seems to have. So they're really, really handy. And we're sort of on such friendly terms now. If I ever go to Darwin, I'm going to catch up with them for a coffee.
Oh, very good.
So is outreach a big part of your job?
It's starting to be. I never thought I'd ever do an outreach sexual health role, but I am. Yes, it's actually quite good because I think like going to the people's houses and showing that you care and that you can actually do like blood tests and stuff and then follow up with them there is really convenient. That's what gets them engaged, and then they see you as like a good guy, good woman.
Yeah, absolutely. Especially the hesitant to come to the clinic.
Absolutely.
Yeah. We've been able to treat things like chlamydia in the home, and we do have some scope for giving LA bacillin, but I haven't had to actually do that in the home as yet. But we do have sort of a little bit of a clause with our medical director that we can consider it on some special circumstances.
Yeah. But otherwise, you would get Yeah. Good. Yeah.
What would you say you enjoy the most about your job?
I do actually really enjoy the outreach, I have to say. Like, I like being, it feels like you're on the field and then you just have to adapt to a completely new situation. Because, like, you're in a clinical environment, it's pretty, like, you can have deviations from your day. But, like, when you're out in outreach, it's like anything could happen. So, I don't know, I find that quite exciting. That's kind of what my favourite part. Being able to like see people's environment. And I don't just think only in a sexual health sphere, I sort of see like the whole person. You sort of understand a bit of a person by their lifestyle and if they need environmental health sort of assistance, like we have an environmental health team. So that's a good opportunity, even like opportunistically refer it there. Or if someone discloses their mental health sort of struggles with you when they're at home because they're more comfortable doing that, then you can give them a SUB referral. So I feel like in that outreach scenario, there's more opportunities to address the client holistically.
Yeah.
Because you're not giving them the pressures of being in a clinical environment. They feel like they have to stick to a script and within a time frame. Like you've got time because you're there at their house.
You know? Yeah. You're in their home.
Yeah.
Yeah.
And they're probably more willing to share because you've taken the effort, you put in the effort to actually go there and see them.
Yeah, that's good.
I like that.
Yeah.
But also I really like quality improvement. So I guess I'm a bit of a nerd, but I like auditing, I guess. And I've been doing a lot of auditing recently. I'm actually like, this is actually quite fun. I like that. Yeah.
Like you like the investigator,
Yeah.
being a detective and working it out why things aren't working.
Mm-hmm. Yeah.
We need people like you. I think that's important. Yeah. Yeah.
I used to hate it, but I love it. Like I think the past year or two, I just really like it. Yeah. It's weird to just turn around.
Yeah.
Actually, we're still kind of a little bit on the topic, so I might ask Helen's question now. So, what does outreach look like for you in the city?
Well, I mean, when it comes to outreach, it's sort of like if the client hasn't engaged with actually going to the clinic on their own terms, like that's when outreach will be involved. If they're not really reaching, if they're not contactable by like their phone or by mail or by other forms of contact, then that's when like we think, okay, maybe we should do a home visit and see how they're going. So it's not like the first point of call because it can be a bit invasive for some people. So you have to also think, okay, not every single person is going to be really welcoming to like
No.
a clinician coming to their front door. So you have to sort of just look through the notes, see if you can get a bit of a feel of the client based on what's been written by other clinicians, and then decide whether or not I'm going to go ahead with this outreach appointment or if something else needs to be involved. Best practice as well is to have either your ALO or an AHP attend with you as well. So when we don't have ones available at Derval, we use the ones at MCDC to come with us because they have a whole team of ALOs at MCDC.
Do you phone them first and say?
Oh, we try everything.
You try
everything. We try it all first. Outreach is like the last step.
But do you say to them, is it okay if we come to your house?
I've actually done that once or twice.
Yeah.
Yeah. Someone's like, I really can't come to the clinic. So, okay. Well, would you like me to take your bloods at yours? And they're like, oh, actually, that'd be great. And then actually, yeah. But then I don't think that person was at home at the time. But it's still something, you know, like, yeah, you want to get the concept.
I went to somebody's house, I don't know how many times, it must have been maybe 14 times last year. Quite often it was either myself and one of our AHPs or it was an ALO from Derval, or the other visits were with an AHP from MCDC, but we just kept turning up because it was really, really critical that this girl got some treatment. And then one time we turned up on her doorstep, I'm banging on the door, she answers and she goes, oh, I've got COVID. It's like, oh my goodness, we fall straight into that one kind of thing. So you do need to be a little bit careful and mindful that there are other things going on with that person as well. So even though she was there, we couldn't do anything about it. We had to keep our distance. But
Yeah.
But in the end, it took us almost 7 months, and it took us 7 months to do the whole job that we needed to with her.
Mm.
But that was a lot of outreach.
Yeah. Was there any other? Oh no, that was it.
I think that one was answered. So what would you say some of your biggest barriers are? And not engaging?
Not engaging. So you organise somebody to have an appointment at 2:00 tomorrow, and then they don't show up and you can't find them. And some of the other things seems to be the Swiss cheese effect, that the person rings up, makes an appointment, but they don't update their details, and they somehow get through reception and their details aren't updated, and they get through the clinician and their details aren't updated, and then I get the positive result and I know that the person has Ebola, but all the address I've got is Alice Springs and nothing else to go on. And I go, that's kind of a little bit hard to then try and find this patient.
Yeah, okay. Well, contact details are so important, and they change all the time. You know, you've got to ask people every time they come in, have you moved, or has your mobile changed, or
We try to find interesting ways of getting updated details, and sometimes pathology results might give a bit of a clue, or the COVID. It was really one good thing about COVID is a lot of people had their vaccinations and they filled out their forms, and then those forms got scanned into their notes, and that was a good way of sort of just checking up on a phone number or an address or a next of kin or some little link to then be able to find them.
Yeah. Okay.
I 100% agree with you. I was going to say that, and it's also my biggest barrier. Not updated like contact details, next of kin details, address, phone numbers, everything. Every single thing. Because the number of times I've called a number and they're like, it's disconnected. I'm like, oh my God. No. Oh, yes.
So you both mentioned that you've worked in mainstream sexual health. How do you find that different now to working in community control?
I love with sexual health, people can ring up and to the receptionist they can say, hello, I'd like to make an appointment for an implant-on, or hello, I'd like to make an appointment for an STI check. In mainstream AMS, people are not going to do that. and so we have to find creative ways of being able to get them into our door. And often it is opportunistic that they go and see the AHP, they go and see the doctor, and then they come around to us, or they come to us by their results that the doctor's already done. It's really, really different. And in sexual health, we could be a lot more open about why people were actually coming to visit, whereas at Derble, we have to be a lot more discreet and really careful not to breach their confidentiality. And even then just coming and walking around the corridor with me, people might go, oh, that's the sexual health nurse, and I might be outing somebody about why they're here.
Yeah.
So it's, trickier.
Yeah.
Mm-hmm. Yeah, I think also something is interesting. It's definitely something with the AMS and just Aboriginal health in general. It's like the men's and women's business. Most clients, if they're female, they want to see another female and male, another male. So that's just something that was, I guess, interesting because like I'm used to all people like wanting to see me or see another clinician. You know, like it was really gender preference, or like they'd be happy to see someone, but then if they see someone of the opposite gender, then they just won't bring up their sexual health stuff. Like that was the big no. So
and with that, sometimes it's a real surprise. I had a man, a doctor asked me to see a particular man, and I sort of looked and went, oh, this is going to be really, really difficult. I don't think I'm going to get anywhere at all. But he came into the room. I just said, elephant in the room, I'm a woman, I'm a white woman. Is it okay to talk to you? And he goes, yep, not a problem. And then we got a rapport going, and he told me things that he had not spoken to the doctor about at all. So sometimes
it does actually work out, yeah.
And you can't predict it. You can't know, oh, this one's going to be easy and this one's going to be
It's like it's not like younger versus older or anything like that. It is like anyone. Like
You have to just dip your toe in, just see if it's okay to go further.
Yeah. I think that's a really good message because often, it's tagged in, particularly in Aboriginal medical services, that you have to go and see a female if you're female, or you have to go. And, really, it could be down to the individual themselves. They might be actually, like you said, that guy was actually fine with you because you'd asked, you'd said, is it okay? Being respectful and friendly.
I think that's really important,
that.
being respectful and non-judgmental.
Yeah.
I think, like, if you can be a non-judgmental person, like that whole experience, that's the key to building rapport.
Yeah, and just don't assume.
No. Yeah. If anyone's sort of worried about that respect kind of thing, when I first started in sexual health, we used to have paper forms because it was before computers, and one of our forms, I could always ask all the questions and then I'd flip it over, and then the top question was, have you ever been sexually assaulted or abused? And for some reason I could not ask that question. I had a real block with it. But then one day I realised these were all just simply questions, and if I got an answer that I didn't know what to do with, I didn't have to wear it. I just had to go to the next person and go, oh, hey, doc, by the way, this person answered this.
Yeah.
And problem solved.
Yeah.
Didn't have to have any of that worry of, oh, I don't know what I'll do with this.
But at least you asked.
Yeah.
And at least something was addressed. That might not have been addressed if you didn't ask.
Yeah.
It's like almost like any kind of fear you have asking these kind of questions that are important, you just need to sort of leave it behind and put on a sexual health nursing hat and just go into the deep end and ask it.
With leading information before it. So I'm going to ask you because of X, Y, and Z.
Yeah, really good to always have a rationale to why you're asking the question, because otherwise people will be like, what? This is an invasion of my privacy.
Yeah.
So as long as you can rationale, you're fine.
Just as an example of that, if I don't answer this, but if I was to say to Joe, do you have vaginal, anal, or oral sex? I would preface it with, Joe, I'm going to ask you how you have sex because infection can be found in different parts of the body. It gives a good reason for asking it rather than I'm just being a nosy old lady.
Yeah.
And I know what you are and I want to know what you do.
It sounds like you're almost like curious for your own personal game. I just feels weird. So rationale. Always thought it. Yes. Awesome.
Do you find that clients are more like they feel okay to talk about sexual health with you being non-Indigenous?
Oh, that's a hard one. What do you think, Eleanor?
I'm getting a bit of a vibe working at Derble that a lot of our AHPs will actually say it's easier for those of us who are non-Indigenous to ask people to have the syphilis point of care testing because that person, the client's not going to see us at the barbecue at the weekend. Mm. So sometimes you get that feeling that maybe it's all right to talk to us because we aren't a part of the normal community.
Mm. But is that like, is it consistent? Is it hard to say?
Yeah,
is it real, or is it just like everyone's personal notions? It's hard to say, like, oh, it's hard.
Yeah.
I was just wondering if there were people who had some questions, because people have to go, some people because it's 12:30. So was there any questions from anybody out there before we close off?
Not a question, just a comment. Thank you for sharing your stories. That's really interesting.
Oh, thanks, Jude.
So nice. Thank you.
How do you deal with so if someone names a contact and the contact then turns around and says, I haven't had sex with this person, are there ways that you found that work in trying to convince the contact that, yes, you may think that maybe you didn't have oral sex with this, but there might have been other ways of transmission, but also is there like a gentle way? Because I particularly like how you said, how do you have sex, as opposed to trying to explain 10 types of sex. So is there a bit of something that we can use?
Question, because if they straight up say, oh, I haven't had sex with them, it's like, oh, okay, and then you just sort of clarify, maybe I'll say things like, there's penetrative sex, like, like vaginal or anal, and then there's like other types of sex, like oral sex, like have you heard any, like, I don't know, I would like further clarification. I feel a lot of people think penetrative sex is the only type of sex, and there's a lot of ways to have sex, and even kissing is a facilitator for syphilis. So really, like, I guess you just have to cover those bases too. Just don't doubt them, but like ask follow-up questions.
Yeah. Also, it's a bit tricky when you said, but I haven't had sex with that person. So I never named the index.
Yeah.
So I never named the person who I know has the positive result. But if they're in a relationship, I would say, Mary, can you tell Bruce to come in and be tested? And then that's really easy when Mary says, oh, Bruce, I've got syphilis and you need to go and see the doctor and you need some treatment. But we had a case not so long ago where one person was positive, but they wouldn't tell their actual current partner. And then we had to be really creative in ways of getting the partner to come in and be tested. But then that was all negative, which really surprised us. And then we had to make sure that the person came back for their 3 months window period check. And it became really sticky because we can't breach our patients' confidentiality, but the health department was saying to us, but you have to let the other person know. And we're like, well, then you come in and you do that because we can't do that. We can't jeopardise our position.
Yeah.
So that was really tricky as well.
Yeah.
But the health department did say, look, what you could have done is just said to both people, both of you have been named for this. It could have been an infection from a long, long, long time ago, and you just come in and have it all sorted out. And I sort of thought, yeah, maybe that could have worked in this instance if we had thought about it really early on. Yeah, okay. Tricky.
Yes.
It would be so good if we could just go, oh, that question, yeah, I've got the answer, wouldn't that be great? Oh, but that's why it's so good, and that's what I love about working in a team, is that, obviously mindful of confidentiality, but to actually talk with another team member sometimes is really good to say, how should we tackle this? What would be the best for this patient?
Maybe for that person who was the contact, just saying to them, oh, look, is there going to be any harm? When did you last have a screen? And just for peace of mind, because there are infections that don't show symptoms, how about you just come in anyway and have have a test
Yeah.
and some medication if we can get it into you at the same
Yeah,
time.
yeah. Because even for intimate body contact, there can be risk of transmission as well, and people don't sort of think of that as being sex. Yeah, yeah.
Yeah, and also people are not always forthcoming about how much sex they have. They will say they don't have sex, you know. And then I've had a client just the other day, and they're like, nah, I only got the one girl back up in North, and I'm like, oh yeah, and then I just ask the question again, just as part of organic conversation. They're like, yeah, but if you around here in Perth as well, like they're sort of, and then they're more and more, and you're just like, oh yeah, so high risk. Then you go from there, but like it just sometimes just rephrasing the question as well is something that helps people realize, oh, that's actually what you asked. Like I get it now.
Yeah, yeah, yeah.
Thank you. Lovely answers.
Thanks, Brenda.
Thank you. Thank you for coming along. Thanks everyone for joining in. So this will be up on our Aqua YouTube account. And next week we are joined by Siren. Yeah. So we'll see you next Tuesday at 12.
Okay. See you, everyone. Have a good week.
Have a good week.
Bye.